The first topic for this series is abdominal aortic aneurysm, or a AAA. It has a high morbidity and mortality rate. It is a condition that has a high risk of misdiagnosis, and rapid diagnosis can increase the survival rate of symptomatic patients. AAAs occur when there is bulging or a weakened area in the aortic wall. It is diagnosed when the diameter of the aorta is equal to or greater than 3 centimeters. Patients become symptomatic when there is a sudden increase in the wall diameter or rupture of the aorta. Bleeding can occur into either intraperitoneal or retroperitoneal spaces. Intraperitoneal rupture is usually fatal immediately. A AAA has a growth rate of about 1/4 to 1/2 centimetre every year, and risks are strongly associated with advanced age. The aorta is the largest artery in the body. AAA is more common below the kidneys and is also referred to as infrarenal aneurysm. Male patients have increased risk, and most patients are above 60 years of age. The risk increases with the number of years smoking. Family history, hypertension, diabetes, and atherosclerosis are other risk factors, as are genetic disorders of connective tissues, such as Marfan and Ehlers-Danlos syndromes. Uncommon risk factors include abdominal blunt trauma, congenital syndromes such as bicuspid aortic valve or coarctation of the aorta, and rare infection of the aorta by syphilis, salmonella, or staphylococcus. Presenting symptoms are usually back, abdominal, and flank pain, which can mimic any other primary diagnosis. The pain may radiate to chest, thigh, inguinal regions, or scrotum. Lower extremity pain is a result of blood pressing on the femoral nerve. Syncope or near syncope may be experienced. This is due to rapid blood loss and inadequate cerebral perfusion. Sudden death occurs most commonly with intraperitoneal rupture of the aneurysm. Palpable, tender, and pulsatile masses can be felt in an unruptured aneurysm. Ruptured abdominal aneurysm is usually accompanied with abdominal and/or back pain. Patients are usually in a state of shock with tachycardia and hypertension. Acute rupture can also present with periumbilical ecchymosis, Cullen sign, and flank ecchymosis, Gray-Turner sign. The duodenum is usually involved. Patients may present with melena or hematemesis. Retroperitoneal bleeding may lead to scrotal or vulvar hematoma. Airway, breathing, circulation, and level of conscious state is assessed, and any need is attended to before progressing. Patients need to be monitored continuously, with vital signs recorded as frequently as possible. 2 large bore IV lines for intravenous therapy, and fluid balance monitoring. Vigorous fluid therapy can be counterproductive. Give analgesia as required, and FBC, UNEs, LFTs with group and hold, coagulation profiles, and urinalysis tests are carried out. Diagnostic tests should not delay definitive treatment in symptomatic patients. Emergency surgical repair is needed as soon as possible. Fluid or blood resuscitation should not be over-aggressive. It can lead to increased bleeding, which will worsen the patient's condition. A bedside ultrasound can be used for diagnosis for unstable patients, and a CT scan for stable patients. A AAA discovered incidentally and asymptomatic AAAs require vascular referral and blood pressure control. Aneurysms equal to or greater than 5 centimeters have increased risk of rupture.